Chancellor. Your meeting is now live.
Good afternoon and welcome to the Health Overview and Scrutiny panel. I am Councillor Chris Atwell and Chair of this panel. We are meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Until recently, the law stated that all members had to be present in the room to make formal decisions at meetings. However, the law was amended in response to the COVID-19 emergency, and councils are able to hold public meetings virtually. This will be in accordance with the local authorities' coronavirus flexibility of local authority meetings, regulations 2020, number 392, the regulations. Members of the public are invited to view this meeting, and there have been the opportunity for written deputations to be submitted. Those present, those present are requested to keep their microphones on mute and to only turn them on when they are called to speak. Members are requested to keep their cameras turned on at all times. People presenting items are requested to turn their cameras on only when they are presenting their reports. If anyone would like to speak, please write your name in the chat functions and put RTS, request to speak. Each time you speak, it would be very helpful if you could say who you are, so it's clear to everyone watching and listening who is speaking. I would now like to invite those present to introduce themselves. Let me go around the virtual room. Councillor Lee Mason.
Hi, Councillor Lee Mason, present.
Thank you, Lee. Councillor Graham Heaney.
Councillor Graham Heaney, present.
Thank you, Graham. Councillor Leo Madden.
Councillor Leo Madden, present. May I say that I don't know how to use the chat system?
Wave your hand, Leo. We'll get through. Councillor Arthur Agate.
Good afternoon, Chair. Yeah, present and ready, willing and able.
Thank you, Arthur. And Councillor Rosie Rains. No Rosie yet.
Well, I've just been talking to her on the other side, so I know she's got to be there somewhere.
Okay. Well, we'll look out for Rosie when she arrives. Okay. And Jane Dodino from Democratic Services, are you here?
I am, thank you, Chair.
Thank you very much. And now my list of presenters is, I think, a little wrong. So I was expecting Penny Emmerett from Portsmouth Hospitals University NHS Trust. Is Penny with us? Or is something...
Good afternoon.
Hello, Penny. Welcome. Welcome to the panel.
Thank you.
And Leslie Bishop.
I am also here.
You're very welcome. Thank you, Leslie. From Hampshire and Isle of Wight Partnership of CCGs, David Bailey.
Yes.
David. Yep, seen you before. Thank you. Thank you, David. And Helen Atkinson from PCC.
Thank you, Chair. Yes, Councillor, well, I'm here.
There's Helen. And we have a few other people in the room. If you'd like to make yourself known. Who else have we got, Jane?
I thought I saw Dominique there a moment ago. Are you there, Dominique?
Yes, thank you. I'm here. I'm Dominique Latouze, consultant in public health at Portsmouth City Council, here to support Helen Atkinson in case of technical failure or additional questions.
Thank you, Dominique. Thank you. And have we anybody else? We have Semke.
Who's SC?
Hello there. Hi, Claire Semke, Associate Director of Comms at Portsmouth Hospitals Trust. I'm here as an observer and to support ahead of Penny and Leslie today.
Thank you, Claire. Sorry, I couldn't see your name. Thank you. Are you all very welcome?
Sorry, Chair. David Barker, in a similar role to Claire, but supporting David Bailey from the partnership, CCG partnership.
You're very welcome, David, as well. Anybody else that we haven't introduced? No? Okay. Members, any interest to declare?
None from me, Chairman.
Thank you, everybody. So we'll move on to minutes of the previous meeting in July, which start on page 3 of the pack. And moving on to page 4, page 5. Leo, yes.
Sorry, Chair, are you doing matters arising as well as accuracy?
Yes, members have any matters arising. You're on mute, Leo.
Right.
Sorry. Yeah, sorry,
Right.
Leo.
Sorry, that's fine. No. It's like a new toy. Page 3, minutes to the previous meeting 25.
Yeah.
We did ask for the rationale behind the decision to merge Hanway Road and Kingston Crescent surgeries. I haven't seen that, Chair, unless I've missed something, but I've been going through the emails, haven't found anything. I know Hanway Road is still open with some patients, but nevertheless, we do know that sometime back in May, the decision was taken to merge, and I think we are entitled as HOSP to see the reasons behind it. And also, what I'm also interested in is how are the merged surgeries going to cope with so many, such a large intake. Thank you.
Thank you, Leo. We'll note that. Thank you. We'll bring that. We'll bring that back to panel.
Sorry, can somebody contact somebody?
Yeah.
Is it CCG, isn't it? The CCG made a decision.
Absolutely.
Yeah. Okay.
Jane, have you got that?
I have, thank you. Noted.
Okay, thank you.
I'll do that.
That was page 3. Thank you, Leo. Page 4. Page 5. Page 6. And page 7. Page 8. Page 9. And 10. And 11. And finally 12. Okay. Thank you, everyone. Leo, your hand's up from before, I think. Is it? Okay. Thank you. Okay.
Chair, may I suggest that you look at the apologies for absence so that we can record them?
Oh, sorry. My apologies for missing those. Sorry. We've received apologies from Councillor Vivian Ashwell, Councillor Trevor Cartwright, Councillor David Keast, Councillor Philip Raffaelli, and Councillor Steve Weems. And we still have no Rosie Rains at the moment.
No.
Could I suggest, Chairman, that Jane gives her a ring, because literally we've just swapped over to this. We were still working on the other call early, the pre-meeting call.
Okay, I will ask Lisa, my colleague Lisa, to do that.
Thank you.
Thank you.
Yeah. Okay. Thank you. Okay. Item 4. Portsmouth Hospitals University NHS Trust update. If I can welcome back Penny Emmerich and Leslie Bishop to the panel. Hello.
Hello.
Thank you for your time this afternoon. Thank you. Thank you for your paper. Before we move to members' questions, is there anything that you'd like to add to the paper you've already submitted?
Yes, thank you, Chair. If I just provide an update on some of the key things that have changed since the paper was written, and then Leslie and I are happy to share questions between us. So we've got 2 items of update on the agenda. the 111 first piece that we're doing, and then a general update on our preparedness. So I'll cover each of those, and then we can go to questions on either, if that's okay with you, Chair. So we have a very timely update on the 111 first work, because you may have seen coverage of the Secretary of State for Health and Social Care's announcement today, which references Portsmouth and the work that we're doing and that's been covered in the paper. That announcement relates to an intention to roll out the scheme nationally by December to support with the winter preparations and response. And you'll know, in the paper covers, that in this patch, Portsmouth was an early mover, and therefore since the end of June, patients who choose to access urgent care via 111 have already been directed to the most appropriate service for their needs, which includes their ability to get a booked appointment in our emergency department if that's the best thing for the patient. The coverage today talked about a national communications campaign that will be launching in December, but you may also have noticed locally in the patch that we've been running our own campaign, including leaflet drops and advertisements on bus shelters, providing information to patients about encouraging contact with 111 in advance of attending the emergency department. In terms of numbers that are using that service, more than 1,100 patients have now accessed our emergency department via a booked appointment. That was from the beginning of, or by the beginning of September. And we're continuing to gather patient feedback while they're accessing that services to make sure that we can support improvements in the service. You'll notice in the paper that we've also run 4 full system test days where patients attending the emergency department have been supported to access the most appropriate service for their needs via 111. And we've had an absolute focus on patient safety throughout that, to make sure that any individual requiring emergency care can continue to access that through our emergency department. I think, as was reported last time, we have seen an increase in attendances to the emergency department, back up to levels that we saw in advance of the pandemic. And this 111 initiative is a key part of our winter plan and preparedness, which is covered in the second part of the papers. So if I may just call out a couple of things from that second paper, which covers the planning for the second half of this financial year. You'll know that throughout the pandemic, we've prioritised the delivery of urgent and cancer work, and we achieved all of our cancer waiting time targets in June and again in July, and we are planning our resources to make sure that that continues into the future. So we're of course continuing to prioritise our urgent and cancer services, but we are also increasing our capacity for routine elective patients, to make sure that we're able to maintain patient safety around all of our patients, and ensuring that we're reducing the risk of transmission of COVID-19. We've also talked about our plans for preparing for winter, and that includes the launch of the flu vaccination campaign next week, and also maintaining our preparedness for additional COVID-19 patients and potential local outbreaks of the virus. We are currently caring for 14 patients with a positive diagnosis for COVID-19, and we also have to sadly report 2 deaths in the last fortnight. Our thoughts are with both of those families. It was back in June that we reported the last death from COVID-19, and sadly we have had 2 further deaths.
Thank you, Penny. Thank you. We'll move to members' questions on that sad note. Members, questions for Penny? Leo.
Yeah, thank you. Sorry, getting back in again. Thank you very much for that. Penny, it's been mentioned, you mentioned it, but it's also mentioned in other reports about flu vaccination. And I just wondered, and for the first time ever, I do it every year, so I'm a good boy. But I have to say that I'm doing it for the first time ever in a chemist rather than a GP surgery. I mean, I'm not bothered where I do it. But when you say, I think it's the next report, but maybe I've got it wrong. Have you extended the number of venues in Portsmouth where you can get it done? Because clearly with people getting flu vaccinations, they're going to be, if they're going to GP surgeries, for instance, or even coming to chemists with it can be massive queues sometimes. How is that going to be organised? And what have you got a target for the number of people you would like to see having flu injections? Thank you.
So thank you. I think David Bailey is probably best placed to answer your question about flu vaccination for the population as a whole. Our focus, of course, is on making sure that all of our staff are offered the opportunity for a flu vaccination, to make sure that it's a key part of our preparedness and that we're keeping both our staff and patients safe with that vaccination. But in terms of access for the broader population, I'm sure David will be able to pick that up in his report.
Thank you, Penny. Thank you, Leo.
Oh. Comment now that we are actually in the process of arranging the flu vaccination for the winter. And it will be readily available where patients and our population need it. But at this stage, we're just working through that.
Thank you, David. Thank you. Members, I'm not sure if I'm seeing any on the chat, so it might just be as easy to wave your arms around. Graham. Graham, over to you.
Yes, I've tried to open the chat function to write anything, it just won't open. It just stays closed. I can't keep opening it, so I've given up and go back to old-fashioned hand waving. I just wanted to clarify how the system operates in sort of for patients ringing 111 looking for an appointment at ED, because this is obviously a pilot. We're not everywhere is doing this, as I understand it. So if somebody rings 111, they presumably go through to the national 111 number, and they presumably have to identify where they are in order for them to be booked into an appointment in Portsmouth. Is that how it works? And secondly, do the call handlers have access to clinical advice if someone is ringing about something as to whether they should come in for some sort of an emergency or not?
Yeah.
Those are my two questions.
Thank you. So the first question about how the 111 service runs. South Central Ambulance Service are the provider of that service, so they might be able to describe it in more detail to you, but let me have a go at describing it. So of course 111 is a national number, but there are local call centres that, as you absolutely rightly say, direct local calls to that local call centre. At times of surge, of course, there is a national kind of resilience support that would come into play, but any person who would access services in this part of the country would normally go through to that local call handling. So they would know that we are running the pilot that we're running here in Portsmouth, so that they are able to direct them through that route. So in terms of how then that works, and I think your question was whether we have access to the GP record, is that right, when the patients are calling?
Well, it's more about clinical advice.
Graham, we've lost your audio.
Yeah, so it's got it back again. Okay. It's just that someone will ring up and they don't know whether they want to come into emergency. They'll describe what's happening, what they've got.
Absolutely.
The question is, do they then get access to clinical advice because the call handler may not be clear, or the person may not describe it particularly well?
Yeah, so absolutely. So an appointment at the emergency department is only one of a range of outcomes that a patient can get as a result of calling 111. There are many other outcomes that could happen in the normal way. So when you would have called 111 in advance of this pilot, you would go through a process where a call handler would ask you certain questions to determine what needed to happen to you. that still all happens in the normal way. If that call handler determines that you might need to be seen in the hospital rather than in primary care or in one of our urgent treatment centres off-site from here, the calls are then handled by a GP in the clinical assessment service, and David covered some of this in his report as well, because that's commissioned by our CCG. So they have commissioned an additional service, which is the CAS, the clinical assessment service, and GPs would then speak with that patient, and they will have access to the patient's record in order to determine whether or not an appointment at the emergency department is the appropriate outcome for that patient.
Okay, that's helpful, because I didn't quite make the link between the thing in the other report and this one. I wasn't quite sure where the link was, and that's been very helpful. Thank you.
Thank you. Leo? Thank you.
Leo, you've got your hand up.
Oh, sorry.
Oh, was that from before? Okay. We'll get there. Any other questions from members? Penny? I just got one about the feedback. I know it's early days. I just wondered if you had any feel for what the patient feedback is.
So we've had a particular focus on this through the 4 days that we referenced in the report, and the feedback has been largely positive to date. One of the key things that patients have fed back on is the communications in advance of some of this. So actually we're hearing that patients are asking us to be really clear that we would prefer or that we are suggesting that a phone call to 111 in advance of attending ED will support them to access the most appropriate service, and in turn will mean that they're not then waiting in a busy emergency department. So you'll have seen the communications campaign that's happening. That's really important in terms of making sure that our population is supported to understand the right way to access the right services.
Thank you. My other question is, so you said, was it 1100, isn't it, patients up to beginning of September? Is that more or less than you anticipated, or did you not anticipate numbers?
So initially what we were looking at was patients could access that booked appointment. So it was patients who were already using 111 to access their urgent care needs. So in terms of the numbers of patients that end up coming into the emergency department, what we're doing is we're looking at the number of patients who go through to that clinical assessment service that I described, but then through a consultation with the GP end up going somewhere else because that's better for their needs. So we made some assessments of the impact that might have on the numbers of patients coming through to the emergency department. And we had already seen during COVID that a number of our patients were attending our urgent treatment centres for minor injuries and illnesses as well. So I'm not sure that we had a clear view really of how many we might expect would come into a booked appointment, but we've had in the region, I think it's very similar to what Mark described with you last time he was here, between 20 and 30 a day are coming through that booked appointment slot because they're already choosing to access urgent care through 111.
Thank you. And the impact, sorry, on the GPs for the clinical assessment service, has that been looked at or assessed yet?
Yes, so that's part of the ongoing evaluation of the work that we're doing. We have a multidisciplinary project board that's overseeing the progress that we're making, and our GP CAS providers are a core part of that. So making sure that we've got the right availability of services in the right place is really important for this to be effective.
Thank you. Thank you, Penny. Last shout for questions from members. No? Okay. I think that might be it from us. Anything else? Okay, well, there you are. Thank you very much. I'm sorry, Leslie, we didn't get to hear from you, but I think on behalf of the whole panel, we wish you well for the coming week as we discover what's coming our way. And good luck with all your work. Thank you for your time this afternoon.
Thank you very much.
You're very welcome. Okay, item 5. Is David? Yeah, ready? Hello. So our update from Hampshire and Isle of Wight Partnership of CCGs. Thank you for your paper as well. Thorough paper, makes life easier for us. Thank you for that. Anything you'd like to add before we go into questions?
Yes, certainly. So I think the first thing to mention is I'm David Bailey. I'm the Deputy Managing Director, so I'm here for Sarah Tiller today, who's the Managing Director of Fareham and Gosport and South Eastern Hampshire CCGs. I understand it's been about 18 months since the Hampshire Partnership has come to this committee, so I just thought it'd be worthwhile just a quick recap on what the CCG partnership is. So we've got South Eastern Hampshire Fareham and Gosport CCGs, which are local to here, which Sarah Tiller and I represent. We're also in a sort of partnership, so we're separate statutory bodies at the moment, in partnership with the Isle of Wight CCG and North Hampshire CCG. And then separate to the partnership, we've got Portsmouth CCG, West Hampshire CCG and Southampton City CCG. So that's the landscape as it is at the moment. And the first item that is in my paper, well, in Sarah's paper there, is around how the partnership operates and the changes that are on the way. So what we're doing is we're trying to reduce some of the complexity and fragmentation of the various CCGs, and what we've found is that local is working well where we've got it across Hampshire and the Isle of Wight, but we're not really maximising the scale of the Hampshire and Isle of Wight footprint. So there's a bit of work going on to try and bridge that, and what's going to happen is that we're looking to merge the Hampshire Partnership of CCGs, so the 4 CCGs I mentioned, formally merge them into one organisation along with West Hampshire and Southampton City CCG. So we'll have 6 CCGs merged into one. We're still going to have the local aspect, but we will then, in addition, we'll have that be able to utilise that and optimise the working at scale. So that's what we're doing our developments within the sort of Hampshire side of things. As you'll be aware that Portsmouth CCG is a separate statutory body, and in looking at the way we maximise ourselves, Portsmouth CCG are moving closer to the Portsmouth City Council in what we're calling Health and Care Portsmouth, and obviously as we progress, we will continue to work closely with Portsmouth CCG as things develop. So what I wouldn't mind doing at some point during this process is getting some of your views and any views you may have, and we can incorporate that into our design. Okay, just a quick note on some of the other aspects, just to bring out some of the salient points. So I've got a separate paper, as you can see, on our response to COVID. It's quite a bit of data in there. It shows, a lot of the things that we've been doing around the method of access through virtual, etc., changes in location, reductions in services, how we've managed demand, redeployed staff, etc. So I won't go into any more detail of that because there's quite a lot of detail in that separate paper. We've also within there, we then start to talk about, well, that was the COVID response. We've now got restoration, we've got the winter coming, we've got a potential second wave coming, and not least we've got EU exit, which may affect us also. So there's a lot in there, and I think our general approach, which is articulated in that paper, is all about forward planning and anticipation. Okay. The third part there is quite an update on primary care. So we've got the integrated primary care service and some of the things that we've touched on there with Penny around how we're using our out of hours, how we're sort of realigning it with the new world. And there's a little interesting bit there around how we've set a couple of our sites up as hubs for what we call hot, where there's problems with COVID, and then there's a couple of sites that are our sort of what we're calling cold sites, where it's for patients who've not got COVID. So that's that bit. Then there's a section there on Willow and in Gosport. I mean, there's not a lot to say there. Obviously, we've struggled in Gosport, mainly due to reductions in GP workforce. We've had to change the way we've worked, and we're sort of reviewing mainly around recruitment and retention of staff. That's the main thrust on that. A couple of last points to mention. There's a big development in Emsworth, where the Emsworth surgery is on one side of the road, and there's an old Victoria Hospital on the other side of the road, and we're actually converting that. It's a £3.5 million scheme to move the GP practice across the road. Couple of issues with COVID and halting work for a few weeks, but nothing that's insurmountable. That's good. And then exciting news for Gosport around the opening of the Clarence unit, which we've done as part of our COVID response. And that's an old nursing home that we've stepped up again. At the moment it's for 54 patients, but it's a maximum length of stay of 28 days, and it's literally instead of a patient just outlying at different parts of the hospital when they're sort of ready to go, but not quite, they can go into this woodcut home, and what will happen there is they'll get in some intensive therapy, and then the idea is then that they don't then go on to a care home, that they get sufficient help and support that they can actually go home. So this is something that was we've worked closely with Hampshire County Council on this one. It's very similar to the Portsmouth City Council development around the Harry Sopnick house, so it's that type of so I think I did have something in there about 111 first, but obviously Penny has talked in some detail about that, so I won't rehearse that. So that's it really. I just wanted to draw your attention to a few bits, and happy to answer any questions.
David, thank you very much for the presentation. I just must interrupt to welcome Councillor Rains to the meeting. Are you there, Rosie?
Yes, I am. Sorry, I was. I thought I was in, but I wasn't.
Well, it's nice to have you here this afternoon. Rosie, any declarations of interest?
No, none. Thank you.
Thank you. You're welcome. Sorry, David. Thank you for your presentation. Members, questions for David? Oh, you might be doing very well here, David. So Graham, a question for David.
Yes, thank you. I wanted to ask a question about the merger proposal. Now, obviously, as a Portsmouth councillor, it doesn't directly affect us in the city, but I was interested to see that the proposal is now to go for a very big merger of Hampshire, including Southampton, and Portsmouth will be sort of continuing on its own independently. So a couple of questions really is, I'm assuming any formal merger will require Secretary of State approval. And secondly, I wanted to ask what sort of consultation is taking place within the wider Hampshire area about this change with the public. Is that happening?
Yep. So going through both of your points there in succession there. So yeah, yes, you're absolutely right. It has to be formally approved, the merger, and where we are at the moment is that we have to submit a formal application by the end of this month with various financial plans and operational requirements, etc. So that is going through. As part of that, as you quite rightly mentioned there about consultation, as part of that, we do have to demonstrate that we have consulted with stakeholders. In particular, we need to work with the clinical leadership of each of the CCGs, because actually CCGs are member organisations of the GPs. So we have been doing member engagement there. We've been to, obviously we're coming to here today. We've also been to similar organisations across Hampshire that we've scrutiny panels that we've been to. We've also been talking to region about the developments and lots of other stakeholders. So yeah, there's been a extensive consultation process, and as you might imagine, that you do need to evidence that before you do make a merger application. So that will be fully documented as part of that process for the end of the month.
Graham, is that okay? Graham? Is he here? Okay. All right, well, we'll assume that answered Graham's question, unless we hear otherwise. Arthur, you have a question?
Yes, thank you, Chairman. It was merely to ask what consultation came on within the realms of East Hants District Council. I'm not sure of the specifics of East Hants District Council, but I'm assured that we will be picking up each of those. David Barker's on the call. Are you aware of the detail on the East Hampshire?
Thank you, David. I know that as part of this process, there's a sort of route that you take for undertaking consultation for mergers of this sort. So that does involve sort of linking in with a number of key stakeholders, as David has described, and it probably goes slightly further than that into trying to involve patient groups and patient organisations, particularly those linked to our patient participation groups. I know that there will have been sort of formal approaches made to the sort of upper tier local authorities. What I'm not sure about, and we can check for you, is whether that approach also went to the local boroughs and districts. I suspect something did, but it's other people in our organisation who have been handling that specifically. So if you're happy for us to take that point away just to check it, more than happy to, but it's not something that probably David and I have been directly involved in terms of handling that part of the process.
Yeah, I understand that you're not into the nuts and bolts, the bottom end, but I asked the question because the reason I'm here is because I am East Hants District Councillor, and the only time I've seen any reference to this has been the 2 times it's been brought to HOSP. It would be nice to know.
Okay. Well, we can take that back and see what communications have taken place there.
I shall look forward to it.
Okay.
David, you'll give that to our Democratic Services team, and we'll forward it around the panel.
Yeah, will do.
Thank you. I'm sort of slightly, I'm just going to chip in. I'm interested in the organisational design of the new structure and how you're going to bring together, I'm guessing, 6 disparate or differently behaving CCGs.
Yeah, so what obviously we're not coming from a standing start here. We've already sort of got a partnership of 4 CCGs who've got a common executive committee, but with divisional leaders, and obviously I'm part of the South East Hampshire divisional leadership. And we've got that experience that is taking us into the next stage of merging with Southampton and West Hampshire. For some time now, we've had the same chief executive. So Maggie McIsaac is already the chief executive for all 6 CCGs. So we're at that stage as well, and they are sort of running joint operational management, even though there's 3 distinct boards at the moment. But actually, one of the things that we found in the first part of merging the first 4 CCGs is, or the partnership of the 4 CCGs, is that actually we can sort of, before each CCG was doing its own governance and its own like finance and performance committee, audit committees, and trying to deliver the services. So what we found is that we're able to elevate some of the more structural aspects of running an organisation from the divisional. So what the intention is, although we're still in the design stage at the moment, this is not due to become effective till 1st of April next year, is that we will have local divisions, for want of a better phrase, that will be for delivering services and making sure that within their areas that the population is served and looked after their health interests. And then some of the more corporate things like doing the annual report and accounts, for example, that will be done at the higher level. So that's how we'll be approaching it. But like I said, it's not a standing start. We have had this experience of even though it wasn't formal merger of the 4 CCGs, it's still working very closely together.
So we'll be interested to follow developments around that. Graham, welcome back.
Yeah, I'm sorry that I dropped out of the call for about 3 minutes, so I missed most of what David said. So I do apologise, but don't want to go over it again. I'll just pick it up in the minute.
Well, are you sure?
Yeah.
Can't hear him. He's on mute.
You're on mute. Yeah, Graham, you're on mute.
Just goes off as the call. So I caught the last bit what you say about how you have done some previous sort of merging activity. I think don't worry about it.
Are you sure? You're happy to catch up?
It's okay. I'll catch up with it later.
Right. Thank you, Graham. Arthur, is your hand up from before? I can't remember.
No, it's another small point. It's obviously this merger is looking to make a quality improvement in the service. It's just such a huge undertaking to take all these different CCGs virtually under one roof. Presumably there's quite a timescale to this. When do you see this? When do you see return on all this? What's your quality improvement going to be? Is it going to be cost or service to the people who live here?
So the main service improvement I think that we were going to get out of this is that we are very good, and this has been acknowledged, that we're very good at each CCG dealing locally with its issues, with its local issues, working with the GPs, etc. And with we work very closely with PHU, for example. So we're very good at the local aspect. The big benefit for patients is going to be around maximising what we can do at scale. So at the moment, each CCG deals with its own estates issues. Yeah, each CCG has its own way of dealing with, if a GP practice gets into financial trouble, how we deal with it. So what we'll find is that some of the local stuff will carry on. So I'll still work closely with Penny on working out how we deliver elective etc. Targets. But then we'll probably have a group of people more centrally who with more expert knowledge of, say, estates, that will then be able to work through. So we've had to do it as a sort of hobby the Emsworth development, for example, as part of an add-on to our main job, whereas actually we would have been a slicker process if we'd have had a lot more sort of professional estate people that could have worked through that. Similarly, with the way if a GP practice gets into trouble, it'll be like we'll have a possibly, and this is all part of the design. We'll have a task team that can go in and help them out. Whereas at the moment, again, it's part of just our general workload that we have to do that. So it's that maximising scale that is going to be the best outcome for our population.
I must agree with the Emsworth. I mean, that place stayed empty for far too long, and a good use for it. Thank you, Chairman.
You're welcome, Arthur. Any other questions for David? Okay. Thank you for coming to panel this afternoon. I hope it's not another 18 months before we see you again. It'd be interesting to see how the Clarence unit progresses, actually. And I know you got funding up until the end of the financial year, I think.
Yeah.
But it sounds like a good use of that site. And,
absolutely, it's for us. It's really exciting that, despite the pandemic, we've been able to sort of develop something of that scale. Yeah, it's good.
Absolutely. So hopefully we'll see you back here to talk about those things in the coming months, in the new year probably. But thank you for your time this afternoon, David. It's appreciated.
Thank you.
For our paper. It's really helpful.
Thank you very much.
You're welcome. Bye-bye. Okay. Item 6 on the agenda, which is Helen Atkinson, Director of Public Health for Portsmouth. It's Helen. Hello, Helen.
Good afternoon. Councillor Atwell.
Welcome. Welcome. Have we still got Rosie? Sorry, I'm just let me make sure we're all here.
Still here.
Yeah.
Thank you. Good. Helen, thank you very much for your paper. Much like the other presenters, is there anything in addition you'd like to let us know before we move to members' questions?
Councillor, well, I don't think there is. Obviously, work continues. The report was at a point in time. We wanted to provide you with work to date that the team with partners have been working on since March, earlier in the year when the pandemic started. And I've brought Dominique with me as well. So she leads on all of the work we're doing, working with transport and regeneration in the directorate, and also has a lead for the work around physical activity and obesity and homelessness. So between the two of us, we're happy to answer any specific questions.
Well, you're all very welcome. Let's go over to members and questions for Helen and the team. Might be very short. Graham and Kristen. Yeah.
It's about to stand up on the whole care home testing. I know we've had some issues with that. And I think at the beginning of September, it hadn't really got off the ground in Portsmouth. Are we in a position? Whole care home testing for Portsmouth, yeah.
Did we get it?
I think that Councillor Heaney is asking about the national whole care home testing programme, which is led by DHSC, but specific regards to how it's going in Portsmouth. Yep. So yes, as you will be aware, there is a national whole care home testing programme. It started in May with one round, so it was a one round for all care homes, but with the evidence and the review of that first round, it was decided to roll it out nationally ongoing, and there are monthly cycles. So in that monthly cycle, all care homes are encouraged to test all staff on a weekly basis and all residents on a monthly basis. So it is up and running nationally and in Portsmouth. There have been some issues which you'll be aware from the media, mainly due to the current capacity issues in the laboratory testing. So nationally testing, and this is part of Pillar 2. So Pillar 1 testing is the NHS testing that is via the NHS, obviously in the acute sector. And Pillar 2 is all community testing, which includes whole care home testing, home testing kits, which you'll know are now available, as well as the regional testing sites, mobile testing sites, and local testing sites. So the number one priority in Pillar 2 is still whole care home testing. But the demand for testing, and just to note that this is obviously not locally led, this is nationally led by DHSC, has been in the last few weeks, particularly I think with schools going back, the demand has increased considerably, and the laboratory testing, which is obviously part of that, where the swabs are processed to get the results, there has not been enough capacity to meet their level of demand that has increased. So DHSC, and you'll be aware there has been a Secretary of State announcement this week, are increasing the laboratory capacity as we speak, and that is by both increasing weekend coverage for the labs that are already part of the testing programme, as well as bringing new labs on board. Now that is a work in progress. We get weekly updates, and we are aware that there are more, they call them lighthouse labs, coming on. So the expectation, and I probably know as much as you do, the expectation is that in the next few weeks, the laboratory capacity will be up to the demand in testing. However, during that time, we are having to do quite a lot of communications work with residents to encourage only people who are symptomatic to go for testing currently, and also to try to manage the expectation, because obviously with schools going back, there has been an increase in demand. So the whole care home testing is still the priority. It is still underway, and all of our care homes are part of that programme in Portsmouth, and they are getting there. They are in the monthly cycle, and as well as the lab capacity, we are seeing some delays in results, and it's mainly that. So what we are seeing is that they're all care homes going through the cycle. Even with some of the delays in the results, we are working with all of the care homes, and they are going through that process. And we have weekly meetings. I know Councillor Heaney knows this because we do meet weekly with adult social care. And Councillor Heaney, all of our currently care homes are part of the tracking. We work with them, and if we do get any confirmed cases, either in symptomatic residents or asymptomatic residents and staff, they are followed up and support is provided, including IPC, infection prevention control visits from the TCG quality team. So yes is the answer. It's all underway. All our care homes are part of that process, but there have been some issues both with lab capacity and reporting of results.
Okay, and Graham, any supplementary?
That's okay. Thank you. Thanks.
Thank you, Sam. Members? Don't see anyone waving frantically. One other question. I'll jump in. About the above average deaths that sort of happened. Is there any explanation for why our average number was lower than normal for that 3-month period?
Well, I think we can make assumptions. So that, just to be clear, that we report, so that comes from our weekly intelligence summary, which we produce both for Gold, the Council Gold, but it also goes to the Health Protection Board, as well as on our website, and is shared with adult social care, children's services, etc. So we've been reporting on deaths throughout the whole period, and we have seen a lower than expected. And we can only make assumptions, and I would say that was the period that we were in lockdown, and therefore obviously there was less movement, and therefore less other infections being passed, I suppose, or spreading. So as well as obviously the reduction, which was the main reason for lockdown, in COVID spreading, there would have also been other less infection spreading, and people would have been mainly, particularly our older population, would have been out and about less. So we can only assume that that would be the cause of lower than expected deaths in that period.
Yes, it's just got an odd consequence, isn't it, of of the last few months. Thank you, Arthur. Over to you. Arthur, you're on mute. Oh, there we go. Are you there?
That's better. Couple of questions, Chairman. One is that item 5, test and trace. We'd like, well, I'd like to know how that's progressing locally. And the other thing is the very first line of that tracing has been highly iterative. I can't find that word in my English Oxford Dictionary.
You'll probably recognise that some of the report was taken from the national, directly from some of the national letters and information. So basically, what they were saying is that it was developing in time and stages, iteratively, in terms of, so it wasn't all, so the national test and trace programme didn't go live and it wasn't up and running on one day. It was developing, and it is continuing to change and develop, which I suppose goes back to your main question, which is what's happening in test and trace locally. So you'll be aware that throughout the pandemic, the guidance, the policies and the delivery have changed fairly regularly in terms of what national government have advised, and the expectation on both the NHS and then obviously Public Health England and local authorities locally has changed rapidly. And we are used to getting instructions quite often on a Friday for delivery at the beginning of the next week. So you'll be aware of that, and that has been for our colleagues across the system in adult social care, schools, children's services, the NHS and ourselves. So to explain where we are on test and trace, so it was set up nationally, and it was, which is written in the paper, I won't go through it, but it was a combination of a national contact tracing service that was via contracts from DHSC directly with national companies. And then that was the tier 3, which was seen as the non-complex contact tracing. And for people who were confirmed cases that didn't have any, they say non-complex, there weren't any specific concerns in terms of high-risk settings that those people either lived in or worked in. And then more complex contact tracing came down to local contact tracing service, which is delivered by our Public Health England local health protection team. And the change has been, which some of you will be aware, is that there is now the option for local authorities to get more involved. We, up until now, have worked very closely with our local PHE, Public Health England health protection teams. We do what we call the consequence of contact tracing. So it's our responsibility in public health and the local authority to support the local health protection team, particularly with where we have existing relationships locally. So for example, if we had a confirmed case in either a care home or in a school, as an example, the initial advice would come from the local health protection team in terms of the clinical follow-up, as well as, you know, in terms of the infection prevention control advice and what needs to be done next. And then we locally get more involved in terms of ensuring that happens, but that also those settings have got the support that they need. So if we take schools, for example, we locally work with our education team with their head teachers in the schools to provide additional guidance advice. We have fortnightly meetings with the head teachers, ensuring that we've got, that we are developing guidance with them, supporting them in preparation, which includes things like flow charts for how they need to respond to a possible or confirmed case. It also includes quite a lot of, we do a standard comms pack with them, which includes standard letters that they can use if they have a case, but it also supports them around advising on who should be tested and guidance around sending children home, etc. That's kind of what we call the consequence management of contacts. And we obviously work very closely also with adult social care and the CCG, who provide the infection prevention control advice. So with the move, and with the move to local governments and local authorities being more involved, this started when we started to see the responsibility shift to local authorities and local lockdowns being implemented in local authorities, mainly, as you know, to date in the northeast, northwest of the country, Scotland and now Wales. We haven't had any local lockdowns in this region as yet. So with that shift of leadership responsibility, and it was piloted or is being piloted in the northeast and northwest currently. So in the areas where there are local lockdowns, local authorities get more involved in the contact tracing, and therefore there was a national proposal that all local authorities could get more involved. And we have, as a region, so we've done it as the whole southeast region, all the directors of public health put in a bid to have a pilot in the southeast. That has now been agreed, but only recently, in the last week. And we are in the first stages. So luckily we hadn't waited. We had put proposals together, which you might be aware have gone through already through the Health Protection Board and the Engagement Board. And recently were reported at the Health, Wellbeing and Adult Social Care Committee. And we have gone into a process to appoint a project manager who sits with us in public health, and have started to recruit internally in the council for, we're calling them reservists, who are volunteers in other teams, who are people in the main at the moment, because we've got about 11 volunteers, who are, for whatever reason, currently in a redeployment pool, which means they can't currently do their normal job. And that's usually because they have to work from home and can't come in to the office. We also have 8 of our own staff from the wellbeing team, because they're already trained and used to doing one-to-one brief intervention work with residents. So we've already got a number of contact tracing volunteers from our own team and from reservists, and have a training program in place. So next week we're hoping to be one of the first. So we're going first in Hampshire and Isle of Wight, and that will obviously include Portsmouth, with Berkshires to take part in the national programme. So it's not completely within our gift what that looks like. It has to be part of the national programme, but we will be hopefully rolling out that training locally. Initially, that contact tracing role that we will have is to follow up confirmed cases who have not been able to be contacted within 24 hours by either the national contact tracing team or the local health protection team. So initially it will start with people who have not been able to be successfully contacted in that 24 hours. And the view being that we might have more ability, because we might have more information about individuals locally, to be able to do that follow-up. But we're hoping that as we move forward, and as the the infection rate goes up, that we will be working alongside our health protection colleagues to do more of that local contact tracing. So clearly at the moment, the infection rate is, although increasing in Portsmouth and Hampshire and the Isle of Wight, we're still not at, which you can see from the appendices and the presentations that we shared, you'll see that we're not anywhere near the infection rate that currently some of our colleagues in the northeast and northwest are seeing. But it's fair to say that there is infection, there is virus in the community, and it is spreading, And as we move into winter, we expect to see that infection rate rising. So it's really part of ensuring we've got, alongside our public health England colleagues, enough resource and capacity to manage contact tracing, managing confirmed cases, ensuring and supporting them to self-isolate, and then ensuring that we are managing outbreaks effectively to reduce further spread. That's the whole purpose of this work, really, that we are trying to continuously manage the infection rate as best as we can.
Okay. Thank you for that. It's that is interesting to hear. Test and trace in the southeast effectively is going to be a huge pilot scheme, but everybody's going to be piled into it. Yeah, we look forward to that becoming, because of what we've promised over the winter, very effective. Thank you.
Thank you, Arthur. Helen, for the interested members here and people listening or watching, what is the current infection rate in Portsmouth?
I was just checking my my daily report. So currently, because as you can imagine, it does vary. We are at 11.2 rate per 100,000. So that's 11.2 cases per 100,000 for Hampshire and Isle of Wight. I'll quickly share, and also just to give you comparators, the Isle of Wight is at 7.1, Southampton at 9.5, Hampshire at 12.3. But to give you a comparator, Bolton, who recently joined what is called the watch list, which are the 20 local authority areas with the highest infection rates, they're at 121.9 per 100,000. So you can see the kind of range. And to give you an idea of number of cases in the last 7 days, so this is the most up-to-date data as of, because we're usually about 24 hours by the time we get the data reported. So this was as of the 15th. We had in Portsmouth 13 new cases in the last 7 days. Hampshire had 76, Isle of Wight 6, and Southampton 16. So those numbers are still seen as low. So we do have some of the lowest rates in the region, and we are the second lowest region in the country still. But we expect to see that obviously increasing as we move into winter planning, and which is why we're encouraging, and I think you asked a question earlier about seasonal flu, ensuring which the eligibility for seasonal flu vaccination has increased this year to everybody over 50 and also up to year 7s at school. So we're really encouraging people to have their seasonal flu vaccine for obvious reasons, that we're trying to protect the NHS in terms of obviously increasing, there will be increasing demand. It's important to note actually, which I haven't said, rather than presenting that data, at the moment, all of the infection that we're seeing is mainly community based, and it's also in young adults. So what we are not seeing, so it's mainly, there was a big increase across the region in people returning from holiday and becoming COVID positive quite quickly on return from European holidays, in young adults, 20, 30-year-olds. So it's all in the community. We are only seeing a small translation of that into hospital admissions. So I think there were about 70 across the whole region, which is really low. And in terms of intensive care, only about 4 intensive care beds used for COVID currently. So that is, this is not currently impacting on the NHS, but it's starting to impact. So we're starting to see an increase in GP attendances, community respiratory infections, and 111 activity. But where we were in the first wave, of course, because we weren't testing people initially, we were only testing people in the hospital and in care homes, that's why we saw such a big increase in terms of very, quickly into the impact on the NHS. At this point, we're not seeing that.
Absolutely, and sadly we heard of 2 people who've lost their lives in the last couple of weeks. So, thank you, Helen. Arthur, is that?
Thank you, Chairman. No, that's fine.
Thank you, Arthur.
I'm finished.
Members, anything else for Helen, Dominique? I just one very quick question for me about the Local Resilience Forum. I have to say, I don't know if it was just me, I was a little confused by how many forums and boards have the word local at the front. I was getting a bit confused who does what. It was a shift in tenses in the piece about it. So where are we with the Local Resilience Forum? Because it said that the Strategic Coordinating Group has crucial capabilities, which sort of sounds present tensey. And then a bit later on, it said it will add value. So is it? Where is it?
Apologies for that. It does add value. So the Local Resilience Forum is a really critical part of our emergency response to any major incident, and is a statutory responsibility through the Civil Contingencies Act. So we have a Local Resilience Forum. It's at Hampshire and the Isle of Wight level, and we are key partners alongside all the other upper-tier local authorities and all the lower-tier local authorities, as well as the police, the NHS, and many other organisations. So they take the lead in a major incident for the responsibility of any response to that major incident. We are in a strange time, so they clearly are still a very important part, but we're in a strange time because we would not normally and have never had, to my knowledge, a major incident that has lasted this long and is likely to continue for another, well, at least for another 6, if not months, not long, it might be longer. So we are in a strange time because normally we would have a shorter response in a major incident of, flooding, severe weather, etc. So we have gone into what we're calling a slightly different stage. So we are probably going to step down from major incident. We are imminently doing that, but the SCG will still communicate and meet monthly, and we will still have what we call a partnership activation teleconference weekly to ensure that there's communication across the whole patch, the Hampshire and Isle of Wight patch, across all partners. But we're going into a stabilisation phase, which is what it was decided to be called, where due to the fact that local authorities now have the responsibility around local engagement boards, health protection boards, and local outbreak planning, the leadership is being passed to up-tier local authorities, but we will still continue to meet as a LOF less frequently to ensure that we're communicating across all partners and sharing, obviously, because there's an important role in that we share what we're doing.
Yeah, thank you. Thanks for just helping me out with that. Okay, members, back to members. Any questions for Helen before we let her and her team get back to work? Okay, Helen, thank you. Dominique, sorry we didn't hear from you. Thank you for your time and thank you for the paper, Helen. We will watch what happens in the coming weeks. Thank you very much, Helen. Thank you, members. That concludes this afternoon's HOSP, unless members have any other business that they'd like to let's talk about. No, we're okay. Well, I'll wrap up my last HOSP. Thank you very much for having me. Your next meeting is scheduled for the 19th of November, and I wish you all very well. Thank you.
Sorry to see you on your way, Chairman. It's been a pleasure.
Thank you, Arthur. Thank you, everyone.
Thank you.
Au revoir, à bientôt.
Peter, sorry, yes, I should say, Peter, are we off? I think we're off, yes.